This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
We're going to be talking about advances in facial plastic surgery. And when I proposed this talk to Nora when she invited me, she said, well, that's kind of boring. You know, we should be able to come up with a better title than that. And she suggested, actually, it's not your mother's facelift anymore. And I kind of chuckled, and as it turned out, I thought that's absolutely appropriate because there have been so many advances in facial aesthetic surgery in the past 15, 20 years, even the past 5, and the change is absolutely accelerating that it's really a correct title. So with that, we'll just move forward. You may be asking, and one of the questions I often get asked as an academic aesthetic surgeon, why are we even talking about this at Stanford? Stanford is the land of the Nobel laureates. I went to medical school here, and this is where we're doing groundbreaking research in medicine and biology. So why are we talking about something so seemingly trivial? Well, the fact of the matter is that aesthetic surgery and aesthetic medicine in general is one of the fastest growing areas in medicine today. And as academic physicians, it's incumbent upon us to provide an evidence-based quorum and be able to talk about this in an intelligent fashion with our patients who ask us about this all the time. There's tons of information about aesthetic medicine on the internet, in magazines, on cable TV. We all know, we've all seen that kind of stuff. And now more than ever, both as physicians and as potential patients, we have to be really vigilant about the information that's out there and understand what's really true. Our mission at Stanford Facial Plastic Surgery is to provide the most up-to-date techniques in facial plastic surgery to our patients in a safe and comfortable environment. And moreover, we'd like to provide a really user-friendly experience for our patients, and I think we've really achieved that. And of course, if you have more questions later on, you can always visit the websites, Stanford Face and a few of the others out there which we've developed, and they provide a tremendous amount of information. I think they've provided some useful information to patients in the past. Well, let's move on to talk about aging of the face. This is a stylized cartoon diagram of a male person on the left-hand side, putatively in their 20s, and on the right-hand side, putatively in their 70s or 80s. And there's some changes which have occurred here over time, and let's take a look at these, even though they might be a little bit depressing. The hairline is receded. In the forehead, we see descent of the eyebrow, and counteracting that, we try to lift it, and so we get these horizontal wrinkles in the forehead, or ritids, if I slip up and say that, that's what I'm referring to. The upper eyelid begins to descend due to pressure from the eyebrow and some excess skin in that area. We also get under-eye circles. The cheek descends. The lower eyelid gets pulled down slightly. There's a little bit of laxity of that tissue, and that sets up a small fold in that area. As that cheek descends, it also causes what we call the nasolabial fold, which is a fold which goes from the corner of the nose down to the corner of the mouth. So when I say nasolabial fold, that's what I'll be referring to. When I talk about mid-face ptosis, I'm talking about drooping of this mid-face area right here. The labiomandibular fold is this marionette line that goes from the corner of the mouth down to the edge of the mandible. The jawline, and this jowling is also due to descent of some mid-face and lower face tissue along that jawline, which is normally nice and sort of curvilinear and well-defined. In the neck, we have neck bands and sagging as that tissue starts to loosen as well. A lot of changes there I spoke about. Also changes in the skin texture and tone. I like to break things down into therapeutic categories in my mind, and so when you think about this, and when I think about it, I'd break things down into the superficial changes, the changes to the skin, and also the deeper structural changes. And each of these we approach differently from a clinical point of view. And we'll first talk about the changes in the skin and the superficial changes and what we can do to affect therapeutic modalities for that. Unfortunately, I think the skin is often thought of as simply a covering to the more vital organs inside, and I'd like to dispel that notion, even though I'm not a dermatologist. The skin is actually itself a very complex vital organ with several important purposes. It's oriented horizontally, as shown here in this slide I borrowed from from this website down below, into horizontal layers, the epidermis, the dermis, which is divided into the papillary and reticular layers, and deep to that is the subcutaneous tissue. The most upper level of the epidermis, the most outer layer, is called the stratum corneum, which is essentially the dead cells which are sloughed off. There's the hair follicles, which are present here. There's muscular tissue attached to those hair follicles. There are numerous nerves and sensory endings in your skin. There also are, of course, blood vessels, sweat glands, oil glands. It's really a complex organ whose purpose is temperature regulation, protection, and sensation, and it needs to be thought of that way. How does the skin age? Again, I like to break things down into categories, and we basically have intrinsic causes of skin aging and extrinsic causes. The intrinsic causes are things we really don't have much control over. These are time, aging, the muscle action on that, and there are maybe some therapeutic modalities there we'll talk about in a little bit. Genetic components. We all know people who go out in the sun and do whatever they want. They don't take care of their skin and it still looks magnificent, and they're just dealt the lucky genes, and there's not much you can do about that, actually. And some of us don't have those lucky cards. The extrinsic causes are sun exposure and smoking, and these are things we do have some control over. Before I go any further, the best medicine, as in many other parts of the body, is prevention for the skin. It's important that you cleanse and moisturize your skin on a daily basis. This can be done with any of a variety of different products which are available over the counter, in doctors' offices as well. And it doesn't really matter so much anymore as long as you get some quality products out there. I'm not going to sort of try to pitch any to you. Protection is also very important. Avoidance of sun exposure and avoidance of smoking are critical. Now, you notice I wrote avoidance of sun exposure and not simply putting on sunblock and going out into the sun. This is particularly true in California. I spent several years in Seattle. It wasn't so much of an issue there. But down here, it's not just putting on sunblock. When you go out into the sun with sunblock, you're still irradiating your skin. So you really need to protect it with sunglasses and a hat if you're going to go out there. And the best thing is to try to avoid it if at all possible. Smoking is another thing we do have some control over. Of course, it's difficult to quit. But smoking is bad for you on so many different levels that I think that the skin's probably the least important in those, but it's another reason to quit. Just a few brief words about non-medical grade skin rejuvenation. This could be an entire talk in and of itself. We hear a lot about alpha-hydroxy acids, and I imagine there may be some questions about this, so I thought I'd just address it up front. Alpha-hydroxy acids are derived from plants, and they essentially exfoliate that thin stratum corneum, which I mentioned. As we age, that layer tends to build up and gives an aged, dry appearance to the skin. Simply exfoliating that does help, and if you do a deep enough peel in that area, you may actually get some collagen formation. Glycolic acids are the one you probably hear about the most. That is simply a type of alpha-hydroxy acid derived from sugarcane, and that comes in various different strengths, and based on the strength, you get more or less of an effect. The 8 to 15% glycolics are what you'll see in many of the products that are available out there for cleansing of your skin on a daily basis, and I do recommend that if you're going to do a daily cleanser, you use something with a little bit of glycolic in it. These strengths are perfectly fine to use in over-the-counter products. 30 to 50% glycolics are what we use in quote-unquote glycolic peels, which you may hear about. And these you will obtain usually in a physician's office or under an esthetician's care. And this is a stronger peel. It may leave a little bit of pinkness to your skin, has a little bit more of a refreshing effect on your skin. 70% glycolic peels are essentially medical-grade glycolic peels. It takes a thicker layer of your skin off, has a little bit more downtime associated with it. And with that, we'll talk more about medical-grade skin rejuvenation options. The techniques for medical-grade skin rejuvenation were originally ablative. And the other category, which is a bit newer, are the non-ablative skin rejuvenation options. The ablative rejuvenation options remove that top layer of your skin, the epidermis and a portion of the dermis. And through the healing process, you end up with younger appearing skin. These techniques include dermabrasion, which has been around for 100 years, as have chemical peels, whereby you use some chemical energy to actually use a chemical to burn off that top layer down into the upper dermis. During the healing process, in the end, you end up looking with having younger appearing skin. And ablative lasers, such as the CO2 laser. The non-ablative techniques do not remove that top layer, but try to stimulate the deeper layers to end up with more collagen formation and younger appearing skin. And I'll talk about why they do that in a minute. These include the intense pulsed light techniques, or IPL, which you'll hear about, the non-ablative types of lasers, and radiofrequency treatments. Again, all of these techniques work by trying to induce a wound response in that deeper tissue of your skin, and that's how you get your more youthful appearing skin. The concept with ablative skin rejuvenation is to induce a wound healing response in that deeper layer, as I mentioned. After healing, you end up with a thicker layer of epidermis, which is thinned over time, and I'll show you an example of that in a micrograph in just a few minutes. A thicker layer of epidermis, as I mentioned, reorganization of collagen in this deeper layer, which becomes disorganized and less elastic as we age. And the result is younger appearing skin. So this is a sort of a schematic diagram of the laser penetrating down into the upper level of the papillary, of the reticulary dermis. These micrographs are taken from a study done elsewhere. In this, they actually took a specimen before and after an ablative resurfacing procedure was performed. In the left micrograph, again, this is the dermis, this is the epidermis, this is that stratum corneum layer up here, and you can see kind of that sort of dead skin, dried skin up on top, and it's somewhat thickened. There's some uneven pigmentation throughout this basal layer. That leads to the age spots, which we see externally. There's disorganization of this collagen. It kind of looks like a big bowl of spaghetti when it should look more like lasagna. And this, again, this epidermis is a bit thin. After an ablative resurfacing procedure, you can see this collagen is more lasagna-like. It's more layered, even, and flat. The epidermis is thicker and plumper. There's more even pigmentation along that basal layer, which you see externally as more even toned skin. And although it's cut off up here, the stratum corneum doesn't have quite so many dead cell layers up on top. That's all fine microscopically, but what does it mean in real life? This is an example of somebody who underwent a CO2 ablative laser resurfacing procedure. Before is shown on the left-hand side, and we can see some pigment abnormalities, just age spots, and some fine wrinkles throughout the cheek area. And after resurfacing, and this is 1 year later, on the right-hand side, we see much more even skin tone and much fewer wrinkles throughout the area. This resurfacing procedure can also be done around the eyes. This is a different person. The laser resurfacing procedure was performed around here to take care of some crow's feet and some wrinkles around the lower eyelid area. And afterwards, I think you can see that there's much less, much more even pigmentation and much fewer wrinkles, much tighter and younger appearing skin throughout. The upside of ablative laser treatment or any ablative resurfacing procedure, such as a chemical peel or dermabrasion, is that it's an effective technique. And there are well-established results with a well-established track record. These techniques have been around for a while, so we know what we're going to get. The downside is that there's a prolonged recovery time associated with these techniques. There can be redness or pinkness in these areas in patients that we laser, for example, for several months. It starts out red and it works its way down to pink and finally end up with normal skin tone after about 6 months or so. There can be permanent lightening of that skin. So that skin that gets lasered is just a shade lighter. And because of that, we do not do this procedure in patients who are non-fair skinned. That lesson was learned a long time ago. And if you do that in someone with olive skin or darker, you may end up with sort of whitened areas, which is really what you want to avoid. Non-ablative treatments of all types seek to induce a wound response in this deeper layer of skin, bypassing the ablation of the upper layers, thus bypassing the downsides of the redness, the prolonged recovery time, and so on. The goal is to get reorganization of collagen in this deeper layer and theoretically younger appearing skin. So we'll talk about the different techniques. Intense pulsed light, or IPL, has gained a lot of press in the last 5 or 6 years since it was developed. Basically the way it works is it induces new collagen formation by heat stimulation of the dermis with an intense light. This is not a laser, simply intense full spectrum light hitting the skin. There's a coolant that protects the upper layer of skin. The light passes down to the deeper layers and causes heat down in that deep layer and stimulates collagen production and reorganization. The upside of this technique is that there are really minimal risks with it and minimal downtime. It's something you can get done in the office. You may be pink for a few hours or a day. It may actually bring out some pigmentary problems initially, but it really does seem to work best for some things like rosacea. And the downsides of the technique, though, are that it really has minimal effect on wrinkles. And requires multiple treatments. So you don't simply go in for one treatment of IPL. You need to make 5 or 6 trips to the doctor's office to get your IPL done. And at the end, the results may not be so dramatic. Non-ablative lasers are similar to the lasers I mentioned earlier, but basically in the head of the device, they've installed a coolant which fires right before the laser hits, so it protects that epidermis. The epidermis is essentially frozen. The laser passes through it, thaws it but doesn't burn it, goes down to the deeper layers which were not frozen, and basically causes the wound down there. These are nice because they really, again, have minimal downtime, lower risks. You can use them in patients with multiple different skin color types. But the downside, there's a theme going here. The downside is that they're simply not effective. And in fact, the lasers such as the N-Light and the Cool Touch, which were very hot back in 2000, 2001, gained a lot of press and were used in many different offices, essentially have been abandoned because they were simply not effective. It's fine to use something that has no downside, but if there's no upside either, there's really not much point. Another technology I'd like to mention, which is a little different, but kind of goes along the same lines as radiofrequency treatment, and there are a few different devices out there like this. Here the concept, again, is to induce a wound response in this deeper tissue. This time you're using radiofrequency, essentially microwaves. You're cooling the upper layers of the skin, focusing the microwaves in the deeper layers of the skin, the dermis and the subcutaneous tissue, hoping to induce a response there that will result in tightening. Here we go with that theme again. Minimal downtime, lower risks. There are certainly some risks with this. It was initially marketed as a risk-free protocol, but actually things have happened with it. There are multiple treatments required, once again, so you don't go in for one treatment and get done. And it's simply not as effective as surgical techniques. Now notice I mentioned surgical techniques here instead of the ablative lasers. The reason I mention that is because radiofrequency facelifts were initially marketed about 3 or 4 years ago as the replacement for the scalpel. And this was on Oprah. It was huge. And I had many patients ask me why I was even bothering with doing facelifts anymore. I should be doing radiofrequency. The problem was it really didn't pan out to work that way, and I think that they put the cart before the horse to some extent. There weren't a lot of studies that showed that it really worked, and the press sort of ran with it. And now we know that the effects are there, but they're really very minimal. So in selected patients, I think it can be a valuable tool, but it is not a replacement for traditional facelift surgery, and I'll be talking about that later on tonight. And another technology which I think is kind of interesting is fractionated laser treatment. As I mentioned before, the way that the non-ablative lasers sought to bypass the downsides of lasers, traditional ablative lasers, was to bypass the upper level of the skin and simply cause a wound down below. As I mentioned also, they simply weren't effective. The fractionated laser actually does pass all the way through and wounds the skin full thickness down to the upper dermis, but it only treats a fraction of the skin at a time. That's why it's called a fractionated laser. It minimizes the amount of ablation and thus reduces the amount of downtime associated with the treatment. This is an interesting technology to me. It's been around for a couple of years. The studies do show that indeed there is reduced downtime and lower risks. You can use it on multiple different skin types. So you can use it on people with olive skin and darker versus the ablative lasers where you can't. The downside is that multiple treatments, again, are required. It is not as effective as the ablative laser on wrinkles, but I didn't say that it is ineffective. So it does have some upside there, and I think this is an interesting technology. It'd be fun to see how this pans out over the next couple of years. These are a couple examples of this. Now these particular photographs are not my patients. All the rest are. This is provided by one of the companies who has a fractionated type laser, and you can see that it is effective on pigmentary problems here before and after on the forehead. And by the way, I have no interest in any of these companies here tonight. This is an example of a treatment on acne scarring, so it reduces some of the pigmentation problems and can help that quite a bit. So we've talked about skin rejuvenation, treatment of fine and medium depth wrinkles, changes in skin tone which we can get with resurfacing procedures and coloration. What do we do about deeper wrinkles, depressions, folds in the face that may be a little bit too much to handle with a resurfacing procedure? The answer here are the injectables, and this again is a topic that could be in and of itself several hours, but we'll talk about the important aspects and major categories of injectable procedures which can be done in the office. The two major categories of injectables that we use are the fillers and the inhibitors of muscle action, namely botulinum toxin. So botulinum toxin, how does this work? Well, botulinum toxin, as you may or may not know, is literally the toxin derived from the bacterium which causes botulism. Sounds horrible, but it's purified, it's medicinal grade. There are 8 different serotypes of botulinum toxin, and they act at different parts of the neuromuscular junction. This is the end plate, this is the end of the neuron, and this is then your muscle down below. And basically, acetylcholine is a neurotransmitter which is transmitted across, and that's how your signal gets to your muscle, and your muscle knows to contract. Botulinum toxin blocks it at various different points in this pathway, depending on which of the 8 serotypes we're talking about. The 2 serotypes which are used medicinally are botulinum toxin type A, which is under the trade name Botox. So when you hear Botox used synonymously with botulinum toxin, it's really the trade name for that particular type of Botox type A, botulinum type A. There I go, I said it myself. Myoblock is the trade name for botulinum toxin type B. The most commonly used type that you'll hear about is botulinum toxin type A, or Botox. Botox has been around for decades, and this initially was used for treatment of strabismus, eye muscle disorders, blepharospasm, hemifacial spasm, spasm of the muscles of the face, and spasm of the muscles around the voice box or the larynx. It was only in 1987 when Carruthers and Carruthers, a husband and wife team, I believe an ophthalmologist and a dermatologist, noted when they were injecting folks for these other disorders, the wrinkles around the eye got better. And this was sort of an epiphany, and we know how the rest of it went. In 2001, several years ago, there were 1.6 million injections in 850,000 patients in the United States, and I dare say that's probably much, much higher today. This works best for dynamic wrinkles in the upper 1/3 of the face. Botox, or botulinum toxin type A, is FDA approved for use, for cosmetic use, only in the glabella, the area between the eyebrows, but off-label use in other areas of the face is perfectly legal in experienced hands, and that's what we do. What is the actual procedure? Well, you have to know the anatomy of the muscles of the face. And what we do is we make very small injections at various sites in the forehead and around the eyes, for example, to reduce wrinkles in these areas. For example, if we wanted to treat the frown lines between the eyebrows, we would make several small injection sites in the glabellar area there and knock out the corrugator and procerus muscles which cause those lines. If we wanted to treat the crow's feet out here, we would make several small injections in the lateral orbicularis oculi muscle. And if we wanted to treat the forehead wrinkles, we would selectively knock out portions of that muscle. The key is not to knock out too much. You don't want to lose all expressivity, but to take out enough so that you actually have an effect. And there's some other things we can do with Botox. We can actually treat portions of the chin and the neck. We do not want to treat around the mouth too much because we want to make sure you can smile, but definitely underrated. The other things we can do is we can actually cause some neat tricks around the eyebrow. If we knock out the muscles which depress the eyebrow out here, leave the muscle intact above, you actually can get what we call a chemical brow lift, which is a very popular Botox injection protocol. An example of what Botox can do. This is somebody who is frowning as hard as they can to demonstrate those glabellar muscles. And you can see these vertical lines here, these frown lines that are present. We can inject that area with Botox, about 25 to 30 units into this area. And after 5 to 7 days, which is how long it takes for the Botox to work, by the way, you can get very nice relaxation of that area. This is the same person a week later trying as hard as they can to frown. So, it really can improve that area significantly. Again, 5 to 7 days for the effect to occur. It lasts about 3 to 4 months, which is a perfect segue into this next set of questions. I often get questions about this, so I thought I'd just put a slide up with the most common ones. How long will the results last? 3 to 4 months in general is how long they last. Will I need less and less as time goes on? Another one of the more common questions I'm asked. Theoretically, yes. I've seen this in many patients in my practice. This is not a scientific study, but I've definitely noticed that some patients who are coming in 3 times a year for their every 4-month Botox injection over the years have gotten to the point where they only need it twice a year. And they're noticing it too. If I start early, will I avoid the signs of aging? Now that's the ultimate question. Well, theoretically, yes and no. The dynamic wrinkles of the face, which are caused by muscle action, yes, we will treat. Those should be reduced, and if you kept up with the Botox, theoretically, those signs of aging should be reduced. But there are those intrinsic causes of aging which are not due to dynamic movement of muscle. Solar effects, if you're out in the sun, genes, the effects of time, those things will still occur. Gravity will still take its toll. And so Botox is not the answer for everything, but it will definitely help reduce dynamic wrinkles of the face over time. Some sites for Botox, again, the glabellar area, the forehead, we inject the lateral orbital areas for those crow's feet. We can inject the neck. These neck bands actually respond to Botox and the platysma muscle. We actually can inject, sometimes people get peau d'orange or the orange peeling effect on their chin, and we can take care of that with a little bit of Botox as well. What about these other areas? What about the larger folds around the eyes? And what if there's something left after the Botox treatment? Sometimes there can be a fold that's so deep, even though it's dynamic, that there's a static component as well. That's where the fillers come into play. We can use fillers, and we'll talk about the various types in a minute, to reduce the shadow effect of these sulci here, here, and along the labiomandibular fold as well. The most commonly used types of fillers I'll talk about here now. Hyaluronic acid derivatives, such as Restylane and Perlane, which are just a couple of the trade names of various types that are available, are composed of hyaluronic acid gel. Now that is a substance which is present in our soft tissues. This is not an animal-derived substance, so this is relatively safe in terms of allergies. There's really no allergy testing required. It lasts for several months, depending on the area you inject and depending on the person. Some people tend to metabolize it a little bit more quickly. And the only con really is the pain of injection and the fact that it doesn't last forever. We can use it in the lips to plump up the lips or other areas. This has largely replaced collagen in my practice. Collagen previously we used to use was derived from cows or from humans, and there was allergy testing required and theoretical concerns about disease transmission, so this kind of bypasses that because this is chemically derived. Radiesse is another injectable filler material. This is hydroxyapatite gel. Hydroxyapatite is a calcium-based component which is present in our bones. This is a soft gel, though. It's not hard, and it doesn't harden when you inject it. It's chemically sourced, so there's no concerns about disease transmission per se. It's injectable. There's no allergy testing required. This lasts much longer than the Restylane or the Perlane. It lasts for a year or more, again, depending on the site of injection. And again, the downside really is just the pain of injection. We generally use local anesthetic prior to doing these types of injections, so it can be pain-free. Depends on how experienced the physician is doing it, I think. And we do not use this particular substance in the lips anymore, as there were some problems with it in the lips, such as granuloma formation. But it's perfectly acceptable in all other areas of the face. Another really popular one these days is fat transfer. And the concept is great. You take fat from where you don't want it and you put it where you want it. We know that as time goes on, we do lose fat in some areas of our face, and we can transfer fat this way. The source is you, so there's no need for allergy testing. It's usually injectable. I say usually because sometimes we actually take small globules and actually place them without doing an injection. It's a relatively simple procedure, but it does involve another incision somewhere to take a little bit of fat, so there's another sore spot. And the downside is the results can be somewhat inconsistent. You may get some fat cells that live, some that don't make it. There's no way to really predict. So one of the downsides is you may need to get multiple treatments to get that even effect across there. But once they take, they should be permanent. Sculptra is an interesting type of filler. This actually works slightly differently. It's made out of poly-L-lactic acid. This is similar to what we use in some of our sutures as surgeons, which we place in deeper tissue and dissolve and go away over time. What we found is that this tends to set up a reaction in that tissue where there's more collagen formation. So the idea came, what if we can make an injectable form of this that we put into tissues, and it'll thicken that area because it'll induce collagen formation. And that's how this works. It's injectable. Again, there's no donor site required, no allergy testing. The problem is there are multiple injections required. There are delayed results. So if we did an injection, for example, in the submalar areas, which is this area on the cheek where there may be some hollowing, the effects are not immediate. You go home, the swelling goes down from the injection, and it looks like nothing happened. And what happens is over time your body produces collagen and that area thickens, and that's how the effect works. So the results are delayed, and it is somewhat expensive to get multiple treatments. The vials are quite expensive. So we've kind of run through the superficial changes, the skin changes, and different ways of treating it. Again, resurfacing treats fine wrinkles, moderate wrinkles, skin pigment abnormalities, and things like that. The injectables treat sort of the deeper folds and dynamic wrinkles of the face. So we have two major categories of ways of treating those superficial changes. What about the deeper or structural changes to the face? What are the different approaches to try to achieve change there? We'll start with the top of the head and work our way down. In the brow area and in the forehead, like I mentioned before, the eyebrows tend to descend. Overactivity of the muscles of the corrugators and the frontalis set up wrinkles in these areas, and we've talked about treatment of those. But this downward trend of the eyebrow tends to give sort of an angry look or a tired look. And I often have patients come to me and say, I look angry or tired. I don't feel that way. People ask me why I'm angry or tired, and I just don't understand why this is happening. And often it's that the brow has come down. And this is an example of a patient like that. This person is not trying to frown. She has very active corrugator musculature. The eyebrows have descended particularly in the medial area, and this is causing a tired appearance to her, an angry appearance to this whole area, and she is not that way. And she wanted to do something about that that was a little bit more permanent than simply treating with Botox. The surgical answer to this is a brow lift procedure, and brow lift procedures have been around for many years. The traditional brow lift procedure involves an incision from one ear all the way around the top to the other. Essentially, you take the forehead and you lift it up, you remove some extra skin. Fairly straightforward concept. Variations of that include placement of the incision. Basically, do you place the incision at the hairline? Do you place it back in the hairline? And these are very specialized types of brow lifts in certain situations are not commonly used for aesthetic surgery. The problem with these techniques is, as you can tell, it's a large incision. You can expect a larger or longer recovery time associated with that. And in addition to that, because the nerves for sensation run from here all the way back over that way, you're actually cutting off those, and you end up with numbness of everything posterior to that incision line. So you have a numb scalp behind there. And you can imagine that would be quite a nuisance. An exciting development in the 1990s was the development of endoscopic techniques for surgery, and in this case, endoscopic brow lift techniques. Using this, we actually were able to make small incisions in the forehead and not have to make that large incision, use specialized instruments and scopes to watch it on the TV screen rather than have to have it all open, go in, release the muscles, release the eyebrows as necessary, and elevate all the tissue upwards without the problems of numbness and with reduced recovery time. So this is one of the first examples of a really minimally invasive technique in aesthetic surgery. There was some controversy initially about whether it was as effective, and studies have shown it is just as effective, and I'll show you a couple examples of very natural appearing effective brow lifts that we've performed. The operation typically lasts a half an hour or up to an hour. It's done under light anesthetic. It's an outpatient surgery, as all the surgeries I'll talk about today are. The recovery is quite brief, 7 days or so. The sutures and staples come out. You can shower the next day. Typical bruising is about 7 to 10 days, and swelling is about the same amount of time. The issues addressed in brow lift are ptosis of the eyebrow, drooping of the eyebrow, and frown lines. It does not address things associated with the lower lid. And I put this stuff up. It may seem somewhat obvious, but these are questions that people often have. So I want to go through each procedure and say what they actually address and what they don't address. Puffy, tired eyes are not addressed. Crow's feet and fine wrinkles. Again, we talked about how resurfacing procedures and Botox are the best way to treat those types of problems. Dark circles and pigmentation under the eye and overpigmentation under the eyes, again, not treated with this. This is the patient that I showed you earlier. So we can see a very sort of harsh look in the medial area, and that was where we concentrated our efforts with this particular brow lift. And afterwards, now granted there's a slight difference in the photography here, but I think you can definitely appreciate that the medial brow is elevated, slightly lateralized, and there's a much more relaxed appearance and open appearance to the entire upper one-third of the face with this. Another example, this is a younger patient who also felt that she always looked tired and somewhat angry. She did not have the same issue with the glabellar area, and she wished this to simply look a little bit more opened up and lightened up. She did not have any surgery in her upper eyelids, but you see much more of the upper eyelid after the endoscopic brow lift, as that's elevated that area into a much more natural, kind of open and bright position. A very natural effect is really what we go for, and what I really strive for in the surgeries that I perform, and I don't want to have this sort of over-operated on look. We'll start working our way down now. Around the eyes, we have aging in a number of different ways. As I mentioned, the eyebrow descends, and the eyebrow and the upper eyelid should be always thought of as a complex. They're always evaluated together. Doesn't necessarily mean you need to address both, but you need to take both into consideration. But as the eyebrow descends, you do have more pressure on the upper eyelid. You have loosening of the tissues of the lower eyelid, and because of that loosening, you have some extra skin formation. You also have herniation of fat from the orbit. Now, the orbit doesn't gain weight. You don't have more fat formation, but simply the tissues loosen that are holding the normal fat of your orbit in place, and it starts to extrude and becomes more visible as puffiness. Puffiness of the eyelid is either due to this fat, extra muscle, or simply fluid changes, which are things which we can't really affect with surgery. The surgical approaches to the upper eyelid have not changed too much over the years. The incision is essentially in that upper eyelid crease. The upper eyelid skin and the lower eyelid skin are very forgiving and tend to heal very nicely. What has changed is our approach once we've made that incision. I think that in the past, surgeons were much more aggressive, and they actually removed more muscle, more fat than they needed to in there. And there were problems afterwards, not just problems with eye closure, which is an obvious problem, but as the healing process went on and years later, patients looked very hollowed out in that area, which was, again, an unnatural look and something we would really like to avoid. So over time, we've become much more conservative with the amount of excision we do in this area. And we've preserved eyelid function and had much better natural-looking, longer-lasting results. This is just a couple of examples of folks who had upper eyelid surgery. Before surgery, we see there's a slight amount of overhang. There's some asymmetry of the eyebrows, which is, again, present afterwards to a certain extent. But we're trying to make this eyelid platform for makeup more symmetric on each side. And after surgery, we see that we have a more symmetric platform for makeup and just more open-eyed look to that area. Again, very natural as well. Another patient who also had, by the way, a brow lift and the upper eyelids worked on. This patient was concerned, again, about pressure. Tired appearance was her concern, and she wanted to have that relieved. And an endoscopic brow lift in combination with removal of a small amount of that skin conservatively ended up with a very nice, natural result afterwards. By the way, the lower eyelids were addressed simply with laser resurfacing. And there's still a tiny bit of pinkness there, I think you can see. And speaking of lower eyelids, there are a couple of different approaches to the lower eyelid that we use. The transconjunctival approach is a long way of saying we make an incision on the inside of the eyelid. And this, I think, is sometimes used, or the term is sometimes used, incisionless lower eyelid surgery, when in fact there of course is an incision. It's just on the inside of the eyelid and you can't see it. With this approach, we can actually go into the inside of the eyelid without making any external incisions, remove some of that fat, which may be causing puffiness. We use this in patients who maybe don't have any extra skin on the outside, maybe just some fine wrinkles, which we can treat with a laser. And there's no reason to make an external incision. This is an example of somebody who did not need any skin removal, and we definitely would not want to. He'd had prior blepharoplasty elsewhere many years earlier and really did not have a lot of extra skin, but really had significant puffiness in the lower area. And afterwards, by going transconjunctivally and removing some of that fat, we got much less that puffiness present. The standard approach for lower eyelid surgery is transcutaneous. You go through the through the outside, right beneath the lashes. Actually, this diagram is not necessarily correct. Usually the incision's really right up under those lashes. And again, the skin's very forgiving and heals very nicely. With this technique, we can actually tighten the skin a little bit, remove a little muscle if there's a little muscle hypertrophy, and remove fat. It's also useful in patients with older eyelids in which sometimes the lower eyelids actually loosen a bit, and we need to do a procedure to tighten it up. And this is an example of somebody who had that procedure. She did not have the tightening, but just the transcutaneous through the skin incision. She had some puffiness and a little bit of extra skin that we wanted to take care of. And afterwards, the incision, by the way, goes right along here and out on both sides. She has a very nice, natural, more youthful appearance to the lower eyelids. The blepharoplasty operation or eyelid operation is typically a 1 to 2 hour procedure depending on how many eyelids you're doing, uppers or lowers or both. It can be done awake or asleep. Patients are outpatients. The sutures are absorbable, or we can take them out in 5 to 7 days. Again, it's a very easy recovery period. Patients are usually up and about quite early the next day, and bruising lasts usually about a week. Again, the issues addressed in blepharoplasty and the issues not addressed. Excess skin, excess muscle, and fat herniation or puffiness of that lower eyelid. Blepharoplasty does not fix crow's feet on the lateral orbital area. It does not fix fine wrinkles. We can use a laser, as I mentioned earlier, and I showed you some photographs of that, to treat those fine wrinkles of the lower eyelid and the other areas of the face. Dark circles and pigmentation are not treated with this. Again, a laser or a chemical peel might be best for that as it thickens and lightens the skin in those areas. And it does not fix drooping of the mid-face area or jowling of the jawline and the neck. In aging of the mid-face, the major issue is this accumulation of fat called the malar fat pad. This malar fat pad normally sits in a nice superior youthful position right on the malar bone at the orbital rim and projects the cheek, and that's the kind of youthful appearance that we may or may not subconsciously visualize when we look at someone who's younger. And as we get older, that tends to descend, and as this pulls down, we get more of a crease in this area. That's termed the nasojugal fold. And we get this nasolabial fold forming from the corner of the nose down to the edge of the mouth. Lifting that malar fat pad is one of the big challenges in facial plastic surgery. I was speaking to somebody before the lecture about this, and the fact of the matter is that this is sort of the Bermuda's Triangle of facial plastic surgery. You can tell that it's an area where we're having difficulties getting a really effective treatment for because there's so many different techniques, and there's no one dominant technique. And we'll talk about a few of those techniques right now. Again, the goal here is to elevate the malar fat pad. The traditional techniques, which are very effective, go through the eyelid incision. So at the same time as a blepharoplasty, when you make that incision through the lower eyelid, you can try to grab that malar fat pad and elevate it superiorly and suture it in a position. Very effective technique. The endoscopic technique was developed in the 1990s, and with this technique we actually use those same endoscopes we use for the endoscopic brow lift in a similar fashion through small incisions and go down and try to elevate that whole fat pad. And I'll show some diagrams of that in a minute. Finally, the percutaneous cheek lifts developed after the millennium, the turn of the millennium, and these techniques use small sutures to try to elevate just that fat pad without making any big incisions at all. The endoscopic mid-face lift, which I mentioned earlier, involves making an incision out here laterally in this temporal tuft of hair, making a dissection with the endoscope down over the malar bone, this bone over the cheek, and sometimes you can aid this by making an incision, you might make an incision up underneath the lip on the gum line to mobilize that whole area. Then the question is, how do you hold it up there during the healing process until it heals into position? And there are a number of different ways. One that I like to use is an absorbable leash device which you place in. It's kind of like some dull hooks that hook into that malar fat pad. And you suture this device up here as a leash, so it kind of extends like this all the way down to the cheek. It lasts for about 6 months or so, and by that time the malar fat pad has healed into its new position. The percutaneous cheek lifts can be done with sutures or newer types of sutures which take their ideas from the porcupine, whose quills have multiple small little hooks in them. And these small hooks actually help make it so difficult to remove that the idea came about to place small little barbs along a permanent suture and see if that would hold tissue, and in fact it does. So using to go back here, you can see these multiple small little barbs along the suture. Normal suture, of course, is smooth. Using either that or traditional suture techniques, we can, again, make a very small incision, much smaller than that, up in this area, and pass those sutures through that malar fat pad and elevate it superiorly. This is the least invasive of all the techniques. You may have heard about cheek lifts and things like that, or percutaneous thread lifts. This is one application of that. And in this, I think it can be quite effective to lift up that malar fat pad. It's a relatively new technology and hasn't yet stood the test of time, but in the past couple of years, we've seen some nice effects with this in this area. So what I recommend to my patients kind of depends on what we talk about and what we end up deciding how much they want to go through in terms of downtime and what they're willing to accept in terms of results. And that's a theme that kind of goes with many of these new techniques. So who is a candidate for a mid-facelift? These are generally patients in one of two different categories. They're either patients who are not ready for a, quote unquote, are not ready for a facelift. These can be patients in their late 30s to early 40s who don't have any problems with the jawline or the neck, because this will not treat that, but have isolated mid-face ptosis or drooping of the mid-face area. Alternatively, it may be patients who indeed are candidates for facelift and may be undergoing a facelift procedure, but need a little bit extra pull in that mid-face area. We may do a mid-face lift to augment that even more. And this is an example of a patient who fits into the latter category. This patient underwent a facelift, chin implant, and mid-facelift through the endoscopic technique with that leash device, which I mentioned earlier. And I've drawn this outline along the cheek to demonstrate the flattening of the cheek, which occurs with age and with mid-face ptosis. Several months after surgery, we see that the mid-face area in the cheek is elevated into a more youthful position. It gives just more of a glow to the face. We've increased the volume in that area. And that's demonstrated by the curve that we can see now here along that outline of the face. She's smiling the same amount in both pictures, by the way. She's not smiling more in the picture on the right. Her cheeks are indeed elevated. It's not a trick of photography. You can also see she has some improvement along the neck and the jawline area. That was not due to the mid-facelift. That was due to the facelift which she underwent. So continuing our journey down the face towards the neck, we can talk about evolution of facelift techniques. And I think it's quite interesting. The facelift techniques are some of the oldest techniques in cosmetic surgery. The term ritidectomy essentially means removal and excision of wrinkles. The original facelifts done at the turn of the last century were direct excisions of wrinkles on the face, right where they occurred. And this evolved eventually into the older facelift techniques, which are subcutaneous lifts, which is what we probably mostly think of when we think of facelifts. So the subcutaneous lifts are essentially an incision in front of and behind the ear, where we just do a dissection as surgeons underneath all of that skin and basically tighten it up and remove what's extra and suture it back down. And that may be what many of you think is a modern facelift surgery, but it really isn't. The problem with this surgery was that these patients often began to droop again pretty quickly. And in fact, in the 70s, I wasn't practicing then, but the people I know who were have told me that they told their patients to expect to come back in 2 years for a tuck-up procedure. So it was expected that in 2 years this would essentially fail. You need to come back and get tightened up again. And as I mentioned before, a lot of what's going on in the face is drooping of the deeper tissues, gravity effects and loosening of the deeper tissues of the face. So by just tightening the skin, you're really not treating the problem. And that's where the SMAS facelifts came into vogue. The SMAS is an acronym for the Superficial Musculoaponeurotic System. That's quite a mouthful, but all you really need to know about that is that the SMAS is a fascial layer which suspends many of the important structures of the face and muscular tissues of the face. And as that descends, that provides a layer that we can, as surgeons, dissect and elevate and get a much more natural, long-lasting result with our facelifts. In the 1980s, the SMAS lifts became popular. And in this case, simply an excision of a small section of the SMAS in the vector that you want to pull, which is sort of superolateral, and suturing of that tissue, in addition to the subcutaneous lift, gave much longer lasting and better natural appearing results. So those are the SMAS lifts. And they're still used, and they can be quite effective. Next came the deep plane lifts, which took this to another level. And there's no pun intended there, but it really did. The deep plane lifts are essentially a further aggressive dissection in the sub-SMAS plane, underneath that SMAS, all the way out extensively into the neck and into the midface. And this provided even a bit more dramatic and, again, natural appearing, though, and long-lasting result. And this is probably the gold standard for facelift today, the deep plane facelift, and it's a modified version of which most people, such as myself, use. The results are quite reliable. What's interesting is now, in the past few years, we're starting to go backwards, and we're starting to do less. The mini lifts, which I put in quotes because there's so many different terms being thrown about for mini lifts so that you don't really know what you're getting when you're getting a mini lift, basically involve less dissection and essentially less of a result. I think there are a couple of reasons for this happening. There are two primary groups of patients who are pushing for the mini lifts. There are people who are coming in younger and younger, so they maybe don't need so much correction, and so maybe there's no reason to do an entire deep plane facelift. If someone comes in their early 40s and just want a small amount of correction or something, a mini lift I think would be perfectly acceptable. There's also the category of patients who maybe would normally be a candidate for a deep plane facelift, but simply don't want to deal with 2 or 3 weeks of bruising and want to have something that maybe has a week to 10 days of bruising at the most, and they can get back to their activities quite quickly and are willing to accept something that isn't perhaps as dramatic. So I think that's one reason why we're kind of going back towards mini lifts in many folks. The term facelift is probably a bad one because obviously there's more to your face than the lower 1/2 and the neck, which is basically what a facelift treats. So it treats neck laxity, banding, jowling. It somewhat treats the nasolabial folds and mid-face ptosis. Again, mid-face lifts are probably the best thing for that. People often think that facelifts do treat the skin wrinkles and things like that simply because you're tightening the skin so much. Well, really, you really don't want to tighten the skin that much surgically because it just doesn't look natural. It's best to do it with the other techniques which I talked about earlier. Typically, the operation is about 2 or 3 hours for a deep plane facelift, less for a mini lift. It's under light anesthesia. It's an outpatient surgery. The sutures and staples come out after about a week or so. Patients can shower the next day. Typical bruising is 14 to 21 days, and I'll show you an example in just a minute. Swelling lasts about 2 or 3 weeks, and makeup can be worn actually fairly quickly, probably less than 2 or 3 weeks. Let's look at a few examples. This is somebody who is a great candidate for a traditional facelift procedure. She has excellent bone structure. She has a nice angle to her neck. She doesn't have a lot of fat. She simply has some extra skin and some jowling. She's really interested in fixing this lower 1/2 of the face and the neck. This is her the day I took her stitches out. So this is 6 or 7 days after the facelift. I hardly ever take pictures. I'm not sure why I did, but I'm glad because now I have this that I can show people when they ask me about what it's like after a facelift. So she has some bruising. It's some under the eyes just from the surgery. It starts to, with gravity, kind of go to different areas, down into this portion of the neck where we didn't even operate, all the way down here. But the incision runs right here, into the ear right there, back around the earlobe and back. I've had her put her hair back so you could see that. These are her photographs about 6 months or a year later. And I think, again, we did nothing in the upper 1/2 of the face, so nothing was done up here. You can see that along her jawline, rather than being squared, which was just one of the stigmata of the aging face, because of the jowling in these areas, she has a more nice, youthful, curvilinear appearance and much a more youthful appearing neck. And I think it's most dramatic on the lateral view, where you can see that her neck and jawline are much more youthful appearing, and her incision, again, is right along here, goes into the ear, back around the ear, and back into the hairline. So folks can often wear their hair back. In this day and age, we have more and more men coming into the practice for this type of surgery, and the most common reason is because they like to wear ties at work in the business world, for example, and they have some extra skin underneath the neck, and they like to deal with that. Again, this is an example of a man who's undergone this procedure, and I'm focusing on the neck. And again, the incisions are very acceptable all the way around the ear. This particular person wears her hair very short, and the incisions are quite acceptable. What about minimally invasive facelifting techniques? Well, I mentioned earlier there are multiple monikers for mini lifts. You see mini lifts advertised all over the place. S-lifts are another term that's thrown out there. Mighty mini lift I've seen out there. Minimal access cranial suspension, or MACS lift, MACS lift. The premise here, again, is to use a smaller incision, less dissection, less downtime, quicker recovery. I think these are all excellent things to strive for. In general, I think the results are less dramatic than with deep plane facelifts, as I mentioned earlier. But again, there may be certain categories of patients for whom this is just perfect. Interestingly, suture lifting can be used to target particular areas of concern. We can use those barbed sutures or other types of sutures to try to lift on that malar fat pad or the jowl area at the time of a mini lift to try to increase our results at the same time. Let's take a look at what a max lift might look like. With this type of lift, we actually don't make an incision behind the ear. We just go just slightly under the earlobe, kind of up into the hairline, do a little zig and a zag, and then we do our dissection out into the face, maybe even not as much as this. And with some of the mini lifts or max lift procedures, we may target certain areas with sutures. We may throw a loop of suture around the malar fat pad and maybe one down into the loop, the upper portion of the neck, a loop into the upper portion of the neck, and kind of tighten those areas and try to maximize what we're getting with our mini lift. So it's a hybrid procedure using newer technologies, and we're trying to go for minimizing the amount of surgery that we're doing. So we've talked about multiple different ways of trying to rejuvenate the face. How do you put this together? Certainly, it's not the same as it was 20 years ago, where you had a brow lift, a blepharoplasty, or a facelift. You had basically 3 different options. You have multiple different options, things we can do in the office, things we can do with longer downtime and maximal result, things which we can do with less downtime and maybe slightly less of a result. It all depends on what your desires are and what the discussion you have with your physician is. For example, if I had a patient who came in and said, you know, whatever age this is, say someone in their 50s, who said, well, I've got these things going on, I do not want to have surgery. I want to know what you can do for me in the office today to try to freshen me up a little bit so I can go out into the world, and I don't want to have any downtime. Well, we may talk about doing some Botox in a few areas, like we talked about earlier. We may talk about Botoxing the glabellar area, taking care of some of the crow's feet out here, maybe even the forehead. Maybe putting some Botox into the the platysmal bands in the neck. And we may use some Restylane or some other filler material to try to address the nasolabial fold areas, the labiomandibular folds, and the nasojugal fold. And with this treatment in the office, within about half an hour, 45 minutes, we can get a nice rejuvenation. Of course, the Botox takes about a week, as I mentioned, to take its effect. Alternatively, I may have the same patient, a clone of that patient, come in who says, you know, I don't mind having surgery. I would like to do something a little more effective than what my sister had, and I want to have something more done. What can you offer me that's sort of minimally invasive? I don't want to go for the whole blue plate special. Well, the endoscopic brow lift is a very nice technique for, as I mentioned earlier and I showed you earlier, for elevating the eyebrows and rejuvenating the upper 1/3 of the face. We may then talk about doing one of the different types of mid-face lifts, a cheek lift, a thread lift for that area, a percutaneous cheek lift, or an endoscopic mid-face lift to try to reduce some of the nasojugal fold and give a more youthful appearance to that area. Patient may or may not also elect to do a mini lift, one of the various different types we talked about, to try to improve the neck and jawline. So we have a number of different choices and combinations of things we can do. Obviously, there are actually an infinite number of combinations. Alternatively, the patient's second sister may come in and say, I want the whole thing done. I'm going to have surgery once. I'm going to get everything done. I want to maximize what I'm going to get. And we may then say, okay, we're going to do the endoscopic brow lift. I think that is a great technique and just as effective as traditional brow lift procedures. We may decide to do an upper and a lower blepharoplasty. The incisions are very acceptable. There's just some bruising associated with it. And we can really rejuvenate that whole complex very nicely with that procedure. We may do a traditional deep plane facelift to really get the maximum improvement along the jawline and the neck. So we have a number of different options depending on the patient and what the patient's desires are. And I often, spend a considerable amount of time actually gauging what I think would be the patient's desires, and we really spend a lot of time communicating and trying to come up with a plan that works for both of us. The bottom line with these minimally invasive techniques, and this is something I say in the office every day, is that they represent the latest advances in facial plastic surgery. They're not all as effective as traditional techniques. Some are, such as the endoscopic brow lift, and some maybe not so much. Even the less effective techniques may be appropriate in certain circumstances. As I mentioned, we need to have a good rapport and talk about what sorts of things and downtime and so on are desired and what sorts of effects are desired, and gauge which would be the most appropriate technique. As new technologies emerge, and I've mentioned a few of them, not all of them will stand the test of time. And it's important that as physicians and as patients, we're really vigilant about this and take everything with a grain of salt when we see it on Oprah, for example. And at the very least, the new technologies which are emerging will add to our armamentarium of techniques which we have to offer our patients as physicians for treatment of the aging face. And I think I've given you a taste of all the different tools we have to offer patients who come into the office. And I'd like to thank you for your attention.
The preceding program was brought to you by Stanford on iTunes U. and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.